Why do nurses love asking about poop? Color, shape, frequency? It's like a personality test for your intestines. Let's break down why bowel elimination is such a big deal in nursing and on your NCLEX. Let's go over normal GI function. So when we eat food, it goes from the mouth to the esophagus, the stomach, and then to the small intestines, where enzymes are added from the gallbladder and pancreas. Then it makes its way through the large intestine to be deposited in the rectum, where it goes out the anus. So the GI tract functions are to digest and absorb nutrients and fluids from the foods we eat, and most of this absorption happens in those intestines. Then anything the body doesn't need, it excretes it as stool, and that's called bowel elimination. GI assessment focuses on the abdomen, but in what order do we assess? Well, most body systems start from inspection to palpation, but in the GI system, we start from inspection, auscultation, percussion, then palpation. Why? Because palpation can stimulate bowel activity and bowel sounds, so we want to auscultate first to get a more accurate assessment. Then we start in the right lower quadrant where there's that ileocecal valve where bowel sounds are most likely to be heard and audible. Then we go clockwise to the left lower quadrant. So for our assessment, what's normal and what's abnormal? Well, normal on inspection and palpation is a soft, flat, or round abdomen. Abnormal is a firm, distended abdomen. A rigid board-like abdomen can indicate peritonitis. Masses or pain can indicate organ inflammation or some kind of disease process. Pain location is also super important, so this mnemonic CPDA can help you remember. So in that right upper quadrant, that's where the gallbladder is, so think C for cholecystitis. Then in the left upper quadrant, that's where the pancreas is. So we have to think if there's pain, it could be pancreatitis, that P. So in the left lower quadrant, that's where the sigmoid colon is, and that's where there's often pain because of diverticulitis. Then that right lower quadrant, that's where the appendix is. So if there's pain, we think appendicitis. On auscultation, normal bowel sounds are active and audible. Hyperactive or bororygmy can indicate diarrhea. Hypoactive can indicate constipation. If we have absent bowel sounds, we're worried about bowel obstruction. Then for color and contents, think we want that nice chocolate brown poop. Red or bloody hematochezia or black and tarry melena can indicate GI bleeding. White or clay-colored stool is an absence of bile, and we're worried about something wrong with that liver. Then fatty, oily steatorrhea is from fat malabsorption, and that's usually due to a condition like cystic fibrosis. Defecation frequency and consistency, we should have 3 bowel movements a week to 1 a day. This should be soft form stool. If we have constipation or diarrhea, that is abnormal. Then we do further assessment of the GI tract by doing diagnostic testing, like a fecal occult blood test. That helps determine if there's microscopic blood in the stool, and that can indicate if there's GI bleeding. Then a barium swallow and enema uses oral and enema barium contrast and takes x-rays of that contrast as it's going through the GI tract to assess GI motility. Then we have a colonoscopy and esophagogastroduodenoscopy. That is when a scope is inserted via the rectum or the throat to visualize that GI tract with a camera. So if the NCLEX gives you a client who just had this procedure, what are we worried about? Well, that scope was poking around that GI tract, and that could lead to a bowel perforation. So we need to monitor for signs of that, like increased heart rate and decreased blood pressure. Also with EGD, an anesthetic spray was sprayed at the back of the throat when that scope was inserted, and they no longer have a gag reflex. So they should remain NPO until that gag reflex returns. Our first quick check, take a moment to answer. When assessing the abdomen, do we palpate or auscultate first? Remember, we auscultate first because palpation can stimulate bowel activity and increase those bowel sounds. So constipation, I want you to think too hard and too slow. So these are hard, dry stool or infrequent bowel movements. That is less than 3 times a week. So this is often caused by inactivity and opioid use, things that slow down those bowel movements. So for interventions, we encourage the 3 F's. That's fluid, 2 to 4 liters a day, and warm drinks helps get that stool moving. Then we have fiber, that fresh fruits and vegetables that help bulk up the stool to make it easier to pass. Then fitness and early ambulation post-op can help increase peristalsis, and all these things can help get that stool moving and out the body. We teach techniques for bowel training. We schedule toileting times to ensure their body gets used to going at the same time every day. And we tell them to not ignore that urge to defecate. We use assistive devices like a bedpan or elevated toilet seat to get them to the toilet when they need to go. Then we give suppositories, enemas, and laxatives to treat that constipation. So if a client complains of intense right lower quadrant pain, like with appendicitis, do we give these medications? No, we do not give these medications for acute abdominal pain like with appendicitis or for signs of bowel obstruction. Why? Because in these instances, that can increase the risk for bowel perforation, so we do not give them. Then long-term laxative use can lead to dependence, so we tell clients to stop these medications as soon as that constipation is resolved. So for diarrhea, I want you to think too fast and too loose. So this is loose, frequent bowel movements greater than 3 times a day. And this is often caused by antibiotics or bacterial infections like Clostridium difficile. Then for interventions, we encourage fluids. So just like we give fluids for constipation to get things moving, we also give it for diarrhea to replace the fluids lost through the stool. If you get a client on the NCLEX with diarrhea, I want you to think 2 things: dehydration and skin integrity. We need to monitor for signs of dehydration like tachycardia because they're losing extra fluid through that stool. Then we keep the perineal skin clean and dry, and this is especially true for our clients with incontinence. So we use absorbent pads and barrier creams to protect that skin. For C. diff, we initiate contact precautions and we wash our hands with soap and water because hand sanitizer alone does not kill those C. diff spores. For our next quick check, take a moment to answer. So what are the 3 F's that treat constipation? Well, those are the things that get things moving in that GI tract: fluid, fiber, and fitness, and early ambulation post-op. Then how can nurses protect perineal skin when a client has diarrhea? Well, we can protect it by keeping that skin clean and dry and using barrier creams and absorbent pads. So a common way to treat constipation we talked about was an enema. That's when we instill solution into the rectum and colon to promote defecation. It helps treat constipation by flushing out that stool, and it helps empty that bowel before procedures like a colonoscopy. So an enema type can vary from isotonic, hypotonic to hypertonic. For hypertonic enemas, that causes fluid to leave the cell. So we do not want to give it to clients who are dehydrated or those at risk for dehydration like infants. For enema insertion, we give warm fluids. Cold fluids can cause cramping in that colon. If the NCLEX asks you what position for enema insertion, you say left sims. That's left sideline with the right knee flex. That's because that position allows for the tubing to go in with the natural curve of the colon. Then we insert the tubing 3 to 4 inches or 7 to 10 centimeters, and we slowly raise the bag to allow that fluid to go down by gravity. Then cramping and abdominal distension are expected due to that fluid distending the colon. Lastly, if discomfort does occur, we lower that bag and we clamp the tubing and assess the client. For our next quick check, take a moment to answer. What position is best for enema insertion? Well, that's that left sims, left sideline with the right knee flex, because when we insert the tubing, it follows the natural curve of the colon. Clients who can't defecate through the rectum, they need to have an ostomy, a surgical opening in the abdomen for bowel elimination. For an ileostomy, that's in the small intestine, and it's higher up in the GI tract, so the stool is more liquid, so these clients are at increased risk for dehydration. Then a colostomy is in the large intestine, lower in the GI tract, so the stool is more formed. After surgery, they will stool through a stoma and into a pouch, and that pouch must be emptied and changed regularly. This device consists of an adhesive skin barrier that goes around the stoma and a pouch that comes off of it. So as nurses, we need to provide and teach ostomy care. So after ostomy surgery, that stoma should appear pink or brick red, and that's a healthy stoma. If that stoma is pale, blue, or black, that indicates decreased perfusion. You need to immediately call that healthcare provider. We need to cut that skin barrier about 1/8 inch or 2 to 3 milliliters larger than the stoma. If it's too big, that stool can touch the skin and cause skin breakdown, or if it's too small, it can constrict the stoma. We need to empty that pouch when it's 1/3 full, because if we let it fill up too much, it can leak or detach from the client. In addition to teaching them ostomy care, we need to teach the clients to avoid food that produce excessive gas or odor like broccoli and eggs, because excessive odor can be embarrassing and excessive gas can cause that pouch to balloon up and detach. We need increased fluid intake, especially our clients with ileostomy, because they have an increased risk for dehydration. We need to teach them to perform their own ostomy care. Remember, they had a major change to their body image due to this ostomy, so this can help increase their self-esteem. Our last quick check, take a moment to answer. When should the client empty the ileostomy pouch? Well, that's when it's 1/3 full, because if we let it get too full, it can cause leakage or it can detach. Then, what kind of foods should a client with a colostomy avoid? Well, foods that produce excessive gas that can cause that pouch to balloon up and fall off, or odor, which can be embarrassing. Foods such as broccoli and eggs. Now you know how to master bowel elimination on your NCLEX.